Hi, hello, and welcome to today's class. I'm sure that you all are aware of the fact that many systemic diseases, disorders, and conditions prove to be risk factors for periodontal disease. Although periodontal disease is primarily formed by bacterial origin, researchers have proved that systemic factors are known to play an additive role in the pathophysiology of periodontal disease. Having these in mind, I, Dr. Santo Grace, would like to take you through today's class on the influence of systemic disease on the periodontium. Our contents are effect of endocrine disorders on the periodontium, effect of female sex hormone on the periodontium, effect of hyperparathyroidism on the periodontium, effect of hematologic and immune disorders on the periodontium, effect of genetic disorders on the periodontium, nutritional influences on the periodontium, effect of congenital heart disease on the periodontium, effect of metal intoxication on the periodontium, and effect of stress on the periodontium. Moving on to endocrine disorders. The most common endocrine disorder is diabetes. It is an extremely important disease from a periodontal point of view. Two forms of diabetes are known: diabetes mellitus and diabetes insipidus. Diabetes mellitus is a complex metabolic disorder characterized by chronic hyperglycemia. It occurs by diminished insulin production or by diminished insulin action. Diabetes mellitus can further be of two types, of which the type 2 non-insulin dependent diabetes mellitus is the most common form of the disease. The oral manifestation of diabetes mellitus include chelosis, mucosal drying and cracking, burning mouth and tongue, diminished salivary flow, and alterations in the flora of the oral cavity, with an increase in Candida albicans, streptococci, and staphylococci species. On the periodontium, the clinical features may be enlarged gingiva, sessile or pedunculated gingival polyps, polypoid gingival proliferation, abscess formation, periodontitis, and loosened teeth. The link between diabetes mellitus and periodontal diseases may be explained by three mechanisms: bacterial environment, polymorphonuclear neutrophil function, and altered collagen metabolism. Increase in glucose content is seen in blood and gingival fluid of patients with diabetes. This alters the oral microflora, leading to an increase in anaerobic vibrios, actinomyces species, and capnocytophagia species at the subgingival flora. Also, an increase in aggregatibacter actinomycetum comitans and Porphyromonas gingivalis has been seen. These bacteria are the primary etiologic factors of periodontal disease. The next mechanism is deficiency of polymorphonuclear leukocyte function. Diabetes patients are known to have PMN function deficiencies. This leads to impaired chemotaxis, defective phagocytosis, and impaired adherence. This defect of the polymorphonuclear neutrophils and monocytes leads to inadequate defense and thereby facilitates bacterial proliferation, leading to periodontal disease. The third link is altered collagen metabolism. Chronic hyperglycemia affects the synthesis, maturation and maintenance of collagen and extracellular matrix. The proteins and matrix molecules undergo a non-enzymatic glycosylation, resulting in the formation of accumulated glycation end products AGEs. This formation of AGE occurs in normal glucose levels also, but is excessive in hyperglycemia. The collagen is cross-linked by AGEs, making it less soluble, thereby leading to impaired tissue integrity. As a result, this leads to increased pathogenic collagen breakdown, and thereby the tissue becomes less resistant to periodontal infections. These are the various mechanisms connecting diabetes with periodontal diseases. Here is your assignment question number 1. Find the missing step in the link connecting diabetes and periodontal disease. You can either pause this video and complete the assignment now, or go through the class and come back to the assignment later. The assignment questions are totally 6, and each one comes in split after each subheading. Moving on to the effect of female sex hormone on the periodontium. Gingival alterations are seen during puberty, pregnancy and menopause. These are due to physiological hormonal changes which are characterized by non-specific inflammatory reactions. Puberty is often accompanied by an exaggerated response of the gingiva to plaque. As a result of the local factors, pronounced inflammation, edema, and gingival enlargement may be seen. During menstruation, prevalence of gingivitis increases. Sometimes bleeding gums is seen. Gingival changes in pregnancy is always caused by the presence of bacterial plaque and not by the pregnant conditions. Pregnancy might exaggerate their responses. However, notable changes in the gingiva during pregnancy does not occur in the absence of plaque. Severity of gingivitis starts at the 2nd or 3rd month of pregnancy and reaches its peak by 8th or 9th month. Pronounced ease of bleeding is the most striking clinical feature. The marginal and interdental gingiva are erythematous, pit on pressure, appear smooth and shiny, and sometimes present a raspberry-like appearance. These are usually painless unless complicated by acute infections. Overproduction of gonadotrophins at the first trimester and increased estrogen and progesterone levels at the 3rd trimester are the causes for this increase in inflammation. During menopause, the usual rhythmic hormonal fluctuations of the female cycle are ended as estradiol ceases to be the major circulating estrogen. This leads to gingivostomatitis. The gingiva and oral mucosa are dry and shiny and bleed easily. The patient complains of dry, burning sensation associated with extreme sensitivity to thermal changes, abnormal taste, sensation, as salty, peppery or sour taste. Moving on, to the effect of hyperparathyroidism on the periodontium. Parathyroid hypersecretion leads to demineralization of skeleton, increased osteoclastic activity with proliferation of the connective tissue and enlarged marrow spaces. This disease is called osteitis fibrosa cystica or von Recklinghausen bone disease. The marked feature is loss of lamina dura caused due to widening of pedial space. This disease is also seen in Paget's disease, fibrous dysplasia and osteomalacia. Fill in the blanks. 5 questions, each carries 1 mark. Everything is related to either the effect of female sex hormones or hyperparathyroidism on the periodontium. Kindly pause and fill the answers, or you can get back to these questions again and fill them later. Next in line is the effect of hematologic and immune disorders on the periodontium. Gingival and periodontal disturbances associated with blood discresis must be viewed in terms of a fundamental relationship between oral tissues and blood cells. Petechiae and ecchymosis are the most commonly observed signs in the soft palate and are the signs of underlying bleeding disorders. The various hematologic disorders affecting periodontium are neutropenia, agranulocytosis, leukemia, anemia, thrombocytopenia and A-gamma globulinemia. A-gamma globulinemia is the antibody deficiency disorder associated with periodontal disease. Neutropenia is a blood disorder that results in low levels of circulating neutrophils, leading to impaired immune responses. Agranulocytosis is more severe neutropenia involving neutrophils, basophils and eosinophils. In this condition, the gingival margin may or may not be involved. Hemorrhage, necrosis, increased salivation and fetid odor are the clinical features. Leukemia are WBC disorders. The oral and periodontal manifestation of leukemia may include leukemic infiltration, bleeding, oral ulcerations and infections. Anemia is manifested by a reduction in the number of erythrocytes and hemoglobin. They may be of different kinds such as pernicious anemia, sickle cell anemia, iron deficiency anemia or aplastic anemia. The oral signs may include changes in tongue to red, smooth, shiny layers, ulcerations in the oral mucosa, and changes in alveolar bone. Plummer-Vinson syndrome occurs due to iron deficiency anemia. It is characterized by glossitis and ulceration of the oral mucosa. Thrombocytopenia refers to reduction in platelet count resulting from lack of platelet production or increased loss of platelets. This is characterized by spontaneous bleeding, petechiae, hemorrhagic vessels in oral cavity, especially in the palate, tonsillar pillars and buccal mucosa. A-gamma globulinemia is an immune deficiency resulting from inadequate antibody production caused by a deficiency in B cells. These patients are more prone to bacterial infection and aggressive periodontitis. Question number 3. Find out whether the below statements are true or false. As I said earlier, you can pause now and continue with the assignment, or else after the class is over, get back to the assignment. Moving on to the effect of genetic disorders on the periodontium. The most common genetic disorders related to periodontal disease are Chidiac-Higashi syndrome, lazy leukocyte syndrome, leukocyte adhesion deficiency syndrome, Papillon-Lefevre syndrome, and Down syndrome. Chidiac-Higashi syndrome is a rare disease that affects the production of organelles of cells. It causes partial albinism, mild bleeding disorders, and recurrent bacterial infections. Lazy leukocyte syndrome is characterized by susceptibility to severe microbial infections and abnormal inflammatory reactions. Leukocyte adhesion deficiency is a very rare genetic disorder and is most often diagnosed at birth. Immediately after eruption of primary teeth, acute inflammation and proliferation of tissues with rapid bone destruction is seen. Papillon-Lefevre syndrome is characterized by autosomal recessive pattern with a defect of deficiency in cathepsin C. It is characterized by hyperkeratotic skin lesions, severe destruction of the periodontium, and calcification of lamina dura. Down syndrome is caused by chromosomal abnormality and is characterized by mental deficiency and growth retardation. Periodontal disease in Down syndrome is characterized by formation of deep pockets and rapid destruction of periodontal tissues. Here is assignment question number 4. Match the following syndromes or genetic disorders with its correct signs. You can pause the video and do it now, or after the class you can get back to this question also. Moving on to nutritional influences on the periodontium. There are no nutritional deficiencies that by themselves can cause gingivitis or periodontitis, but there are nutritional deficiencies that produces changes in the oral cavity. Here are the most common nutritional influences on the periodontium. Deficiency of vitamin A results in dermatologic, mucosal, and ocular manifestations. It affects epithelial integrity and results in hyperkeratosis and hyperplasia of the gingiva. Vitamin D imbalance leads to osteoporosis of alveolar bone and defective calcification of bone and cementum. Vitamin E serves as an antioxidant and helps in gingival wound healing. Oral changes common to vitamin B complex deficiencies are gingivitis, glossitis, glossodynia, angular cheilitis, and inflammation of the entire oral mucosa. Severe vitamin C deficiency is characterized by scurvy. Gingivitis on patients with vitamin C deficiency is characterized by enlarged hemorrhagic bluish red gingiva. Periodontal pocket formation, osteoporosis of alveolar bone, tooth mobility, hemorrhage, edema, degeneration of gingival and periodontal fibers are other features of vitamin C deficiency. Here is assignment question number 5. This is a crossword puzzle. The clues are given. Moving on to the effect of congenital heart disease on the periodontium. In tetralogy of Fallet, the tongue appears coated, fissured, edematous, and there is extreme reddening of the papilla. In case of metal intoxications as bismuth, lead, and mercury, pigmentation in the gingiva is seen along with mucosal changes. Bismuth intoxication shows bluish black discoloration. Lead intoxication shows linear Burtonian line. Mercury intoxication presents with a metallic taste. Here is the final segment of our class, the effect of stress on the periodontium. Stress and psychosomatic disorders impact the periodontal health through changes in the individual's behavior and through complex interactions among nervous, endocrine, and immune systems. Individuals under stress may have poor oral hygiene, clenching or grinding of teeth, and may smoke frequently. Stress-related immune changes have the potential to affect the pathogenesis of periodontal disease. One mechanism is by increase in cortisol production, by the release of adrenocorticotropic hormone from the pituitary gland. This suppresses the immune responses and makes the tissues prone for infection, thereby leading to stress-induced periodontal destruction by periodontal pathogens. Here is the last assignment, question number 6. Write a short note on the relationship between stress and periodontal disease. To conclude, although plaque and oral biofilm are the primary etiological factors for periodontal disease, systemic conditions may aggravate the disease progression. Therefore, adequate care to our body is required to stay healthy. Prevention is always better than cure. Stay healthy. Bye.